Hi, this is Noelle Seifel, and I'm doing this poster presentation on IM injections, specifically ventrogluteal versus dorsogluteal. So even after 80 years of research on this topic, practice does not reflect evidence-based practice, and there really aren't clear-cut evidence-based practice guidelines. IM injections are very common. There are over 12 billion done annually worldwide. One of my research studies showed that even though they're so common, the success rate of an IM injection was only between 32 to 52%, related to improper site choice or needle choice. And these rates are even lower in obese patients. So even when the unintentional sub-Q injection is not necessarily harmful to the patient's tissue, it can still have a negative impact, such as incorrect administration of vaccinations causing lower immunity levels. You can also get subtherapeutic medication levels, which can lead to symptom relapse and hospital readmissions. One of my articles focused on the ritual or habit of giving injections being a negative issue. One generation of nurses does something a certain way for a long time, and then they pass the unsubstantiated claims down to the next generation. Overall, the dorsogluteal site is the most commonly used by nurses, mostly because of personal preference or familiarity, but evidence supports that the site should no longer be used routinely. The settings that these studies benefit is anywhere that does IM injections, such as hospitals, outpatient clinics, or any place that does vaccinations. The patient population is anyone that receives IM injections. For instance, patients getting IM antibiotics. Usual patient outcomes can vary from a successful IM injection to unsuccessful with no apparent reaction, or to mild discomfort, all the way to tissue necrosis and paralysis. Two of the articles I researched were discursive articles that use literature review from multiple studies. And the third article was a cross-sectional study done on 145 volunteers from a university in Australia. The cross-sectional study used demographic data and anatomical measurements to attempt to design a algorithm for best IM injection site and needle choice. None of the research articles I looked at had a definitive answer. Even with the algorithm, you need such different information for males and females. For females, you need weight, BMI, and waist circumference, and for males, you need to physically measure the distance between bony prominences to come up with the algorithm. Then even when you have this algorithm, you still only have a 75 to 79% chance of accuracy when you're giving the IM injection. This study also didn't take into account the fat loss that can occur from aging, because they were all university students. So all my articles agree with the choice of needle length and site are important, but there's still no clear-cut guide. Longer needles are generally recommended for women and obese patients. The summary of guidelines for nurses is to assess all variables before choosing the site and the needle, including sex, obesity, sub-Q tissue thickness, and the patient's anatomy. And it's also important to keep up with your continuing education. One of the studies actually showed that the IM injection success rates increased from 52 to 75 after nurses were given additional training. And then the use of algorithms rather than visual measures should be used whenever possible. And when in doubt, the ventrogluteal site is considered safer than the dorsogluteal. And that's related to the proximity of the gluteal artery and the sciatic nerve when you're giving the dorsogluteal injection. And I put a picture in my poster of that. So in these articles, there is enough evidence that we need further studies and new inventions for safer IM injections, but there really is no clear evidence on exact changes that need to be made. Some inconsistencies in the articles were that one article focused on experience of nurses being a negative, while the other gave a higher rate of accuracy in the experienced nurses. Almost every article I read said the ventrogluteal site is safer, but one article, which was recent and from a nursing journal, said that either was okay. So there's just so much different information. In conclusion, when you're given an IM injection, it's a blind procedure. We really don't know if the injection is truly IM. There are still no clear set guidelines when it comes to safe IM injections, and we need more research to provide a more standard and safer clinical guideline. Really just so much uncertainty remains about IM injections in current clinical practice. And again, if you have to choose, the ventrogluteal site is considered to be the safest. And I did list I put a list of how to do that on my poster. Thank you.